positive cancers, then I'm fairly confident that the HER2 blockade will work. Then I will spare the patient anthracyclines. But regardless, I think doing this is okay. Of course, if you add pertuzumab would be better.
My question, if you don't use anthracycline, you use taxane base
and carbo,
you're going to use 6 cycle of Herceptin and Perjeta.
The full 6 cycle.
Yes. So
it probably work better, isn't it?
Yes, correct. I mean, okay, so this question about how many cycles of anti-HER2 before your surgery would that actually improve outcomes? Intuitively, we say yes, but from memory, based on trial, I think it's about the same. Okay, but here, if let's say we use a non-anthracycline approach, we'll use either PEC carbo or docetaxel carbo with HP.
So we need to see clinical response for this patient actually at this juncture after giving all this 3 to 6 cycle kind of treatment.
Because you expect good response, but if you don't see the good response, then you know what's coming already. So
HER2 is a very weak positive.
Because even 11% is positive.
So let's say she's ER/PR positive, HER2 also 3+. I mean, the triple positive one will be some issue sometimes for neoadjuvant chemo. You see, it's quite very mixed type of response. And with this locally advanced disease, we feel like the surgical treatment will be the same after the neoadjuvant, and we are worried about progression of disease. Actually, it's already like difficult to operate, but at the end of the day, after 6 cycles, still have problem. Then, not easy to handle,
Yeah, especially the triple positives, the PEFCR rates are not that great. But this lady, if her ER is low, her PR is negative, and the HER2 is high, then you hope that it'll be quite good.
Because if you look at it, if you say it's more than 10%, less than 20%, 80% of them are ER negative. So actually more tends to be triple ER negative rather than ER positive.
But if they don't respond well, even then you really suspect triple neg that's hiding there.
So why would want to put there in the slide aromatase inhibitor if you have a suspect that he might not respond with endocrine treatment?
No, this is for approval later on.
Yeah, I mean, at the moment, if we felt that he might not respond well with the endocrine treatment, would we want to still give a trial despite because the ER is just only more than 10%?
So based on guidelines, ER positivity is 1% or more. Okay, so so I mean, it used to be 10% or more, but then they found that even for the low positives, there's actually some benefit. So we should still give, but of course we don't expect much benefit.
So in that sense, how long would you actually offer her? Well, there are some studies to say that you want to extend it up, with addition of 2 years or 5 years of AIs on top of the 5 years. So any comments?
Okay, so if she reaches 5 years, I think you can pat yourself on the back. Okay, as in with no relapse, I mean, you've done well already. Then it's reasonable to go a little bit longer. But in general, the most recent data from ABCSG 16, you really shouldn't go beyond 7 years, because there is actually no benefit at all, AIs wise. And AI, because she's also post-menopausal, she's gonna get older, then she may have osteoporosis and all that.
All the bony complications.
Will you switch to tamoxifen after that?
After 5 years.
Okay, so good question. So so whether you give your AI as much as possible, then you switch to tamoxifen. the concern is, okay, when you give AI, it's already pretty good. It's already very good. So if you look at the long-term studies, right, when you give AI for so long, whatever stuff that you give after that, you may actually be preventing contralateral disease. That means you are doing chemo prevention rather than preventing stage 4 cancer. So it's a discussion that we have to have with people. But of course, extending with tamoxifen is still reasonable because for hormone positive cancer, late relapse is very common. But in this case, if the ER is actually so low, I mean, the benefit is actually very, very little. Yeah.
Okay. Any other comment? Because I think we are approaching 6 o'clock already. This is very good variety of cases that we have. Any comment from the floor? Somebody was asking why would one still do a mammogram in such a large tumor? Any answers? Ying?
Yeah.
Why do we do a mammogram in such a large tumor?
No. Actually, this patient came in with that mammogram from private. So that's why.
The mammogram caused the bleeding, is it?
Yeah. So they have squashed the tumor before.
Because actually in our setting, in such a huge
generally
tumor,
if near fungating, we don't do the mammogram for the ipsilateral area probably.
You do mammogram the contralateral, not the
the important of left side.
Okay, that's answered the question. Any other question from the floor?
I think Prof. Nolia asked a question on is it safe to give tamoxifen since she has uterine myoma?
Okay, so you can still give tamoxifen. It's just that you have to monitor the myoma, as in whether it grows over time or not. But ultimately, the benefit of tamoxifen is probably going to outweigh the risk of the myoma growing, because she's probably going to die from cancer as opposed to anything else. Yeah, I mean, in general for hormone positive breast cancers.
Aisha is asking about this. If Kylie said don't see carbo HP, worried about TNBC, hence addition of carbo.
No, so TCHP or dosicarbo and Herceptin has been compared already with ACT and Herceptin, and it shows, I mean, the outcomes were pretty okay. Yeah, although, okay, it wasn't a direct comparison, but the outcomes are still pretty good. So based on the BCRNG 006 trial, so we can, so it is a standard regimen now for HER2 positive. Yeah.
Roche have this little card that tell you like different type of regime. It's like what you call that? It's like a card of like you order food. Like you can order this or this.
Can you share with us? Can you share with us then? Okay, I think it has been a good discussion. Wide range of cases. You can see now how the need of using more advanced types of chemo treatment as well as immuno treatment, which is added up cost, but it's an eye opener for most of us here. And
can I ask one question, sir?
Yeah,
if
sure.
That patient, the last patients, want to have breast reconstructions, will any one of you offer it?
Oh.
After the neoadjuvant, if she got quite good response, her skins are okay. Will anyone offer it?
I think so.
Not.
I won't.
I will.
It would be delayed recon if she really wants.
Yes. If she wants, we delay.
Get radiotherapy in fast.
If a very, very good response, I think maybe can.
She's a very aggressive.
It depends on the responder. It really depends on the response.
She have meds, right? She have meds.
Not yet.
If not,
Oh yeah, she probably will get met soon.
Yes.
Right.
Yes,
so
right.
and I think her survival, if she, as we say, if she can go above 5 years with pack on her back. So the question is, will you offer recon immediately?
There's no yes and no for that question, actually. I don't think there's a yes and no answer.
I will shine away. I'll tell
Depends
her.
on how desperate
Depends on
she wants it.
that's why, yeah.
It's all very
think so.
dependent on the patient. There are some patients who won't let you do a mistake unless you offer recon. You know?
Yeah, that's why.
And then unless you offer recon, then you offer it.
Yeah, because it's not going to change much, actually, right? The survival plus recon is not going to change much also. Yeah, I don't think so. Yeah.
If she gets a
waste of time.
Yeah, but if she gets a PEF CR, it's different. Yeah.
But we cannot
That's
know
very
until we
unlikely.
operate. Yeah.
With such a big tumor, I don't think I've ever seen a PET such a big tumor.
Probably
I saw
not.
that CR, but I don't know whether ER positive or not. Chahong, remember?
She is ER
The
positive.
fungating one, PET
Yeah,
CR,
but-
you know. But
Yeah,
I
I've seen
cannot
once,
remember
yeah.
what is the
That
not
one
triple
was
negative.
negative though. That's triple negative, I think.
ER negative, but HER2 is positive.
Positive,
Yeah,
yes.
you give pertuzumab, trastuzumab, and 6 cycle of, I cannot remember what chemo. I think paclitaxel. Yeah,
Yeah.
PCR. Oh my
I
God,
know.
is it?
Oh, good. Amazing.
Yeah,
Okay.
amazing. I have a shock.
6 o'clock.
This one going to be
Alright.
tram. Like if you're going to offer recon, it's going to be tram flap,
Yeah.
right?
Large.
Nothing else.
Yeah. All right. Thank you very much
Okay.
to all the panels. All right. And thank you for the participant. This is very good. Again, thanks a lot, Chahong and C, for organizing this event. We hope we could have a face-to-face event next year. Hope for it.
Yes, next year.
Hopefully.
Yeah. Yes, a word of reminder, we will have another pre-congress session for thyroid endocrine cases on 26th of August. I think this coming Thursday. So for those who have not registered, can please register for that session. Okay. And thank you for attending this particular session at such a
Also
last
got
minute.
one more thing. There's an AGM for breast endocrine chapter on Friday. Okay, whoever breast endocrine chapter members, please attend. Okay.
Okay.
That's on Friday, 6 o'clock, I think.
Can we just send the flyer to reminder?
This letter has been sent out. Okay, Ken. That's one.
Right.
The other one.
And,
the other one is AGM for Academy on Sunday. Please attend that because there's something important in there that we need to be there.
All right.
Okay. Yes.
Sunday.
Yes.
Okay. Sunday next week, isn't it? Right.
Yeah.
Okay. Thank you, everyone.